Hey, hello everyone. This is Sherry with the CGH Health Foundation. And you're seeing me because today is one of our Growing Healthier programs. These are our series of programs on important health topics, and we do them live on Facebook. And this month is Stroke Awareness Month. So our speaker today is going to be Dr. Preeti Joseph. And Dr. Eric Kuhns is filling in for Dr. Bird today. So he'll be interviewing Dr. Joseph about the signs, symptoms, and treatment of stroke. And for next month, Dr. Young Song will be with us talking about sexual health in men and women. So that's our program for next month. And remember that all of our programs are available on our website, the CGH website, if you look for our YouTube channel, and on our Facebook page later. I'll go ahead and turn it over to Dr. Kuhns.
Well, hey, and welcome back. Thanks for having me back. We have suddenly entered into summer here, so I'm appropriately dressed for the summer occasion. But we have some good stuff today with Dr. Joseph. I like to think of her as our new neurologist, but she tells me she's been here 3 years now, so that's a little less new, but well loved, and has a lot of good information for us. It is Stroke Month, and I think public education about stroke is really important because time is so critical. So welcome, Dr. Joseph. Anything you want to say by the way of introduction, or should we just start into questions?
Sure, just start into questions.
All right. So speaking about that, we hear about the golden hour or the importance of time. What are some of the warning signs if someone just seems to be off that we could do to say, geez, maybe you need to get in right away? And why is time so important?
Well, we say time is brain because the longer we go with between trouble and help, the more likely we can have permanent damage. So as soon as we, all of us, recognize that there's a problem, we need to get seen and get evaluated right away, because that's the only way that we can save brain. And once you damage brain, it's hard to recover that. So we don't want that brain damaged forever. We want to rescue as much of that as possible if there's an issue. So warning signs, the acronym that the stroke associations and everything around the United States does for education is the acronym FAST. So F stands for face drooping. So if you notice someone or yourself having some face droop, arm weakness is the A, S is speech difficulty, and T is time to call 911. So those are kind of the classic symptoms that you'll see on posters and on billboards and things when we talk about trying to recognize stroke. But there's lots of other symptoms, of course, as well. But anytime my philosophy, my education for my patients and for my friends is that if you notice something that suddenly changes, that's different, it's better to go in, get evaluated, and the best case scenario, they'll say, well, I don't see anything. You can go home and follow up with your primary care doctor. So I think it's important to just get evaluated if there's a sudden change in any way.
Okay. I like FAST. People who know me from outside of here know that FAST is a good thing. And in this case, it's not only a marker of urgency, but can a good acronym for what to look for. So definitely thanks for that. As far as some of the stuff that they can do now, if you get in early, what are some of the advancements that way?
So one of the things that we can do, if you come in within 4.5 hours, but we would really like someone to come in within the hour of having symptoms, is something IV. There's an IV medicine called TPA that can be injected and given to try and block or try to open up arteries or something that's blocked. And the other is in case that there's a clot in the brain and one of the blood vessels, then we can actually go in and remove that clot through what's called a mechanical thrombectomy. So there are many options available, but the quickest one that we have to deal with is the IV medication, the IV TPA, and trying to get that done. The regulations say within 4.5 hours, but the faster the better.
Okay. So, because I'm a primary care doctor and I'm all about prevention that way, what are some of the things that we can think about in terms of trying to prevent stroke from happening? The best stroke is one that never happens to begin with, right?
Right. So we want to keep that brain as open as far as blood flow as possible. So that's one of the core things. So when we think about how do we get that brain as much blood as possible to avoid damaging the brain, we talk about blood pressure that can squeeze down on the blood vessels and not cause the brain to get as much blood flow. We talk about diabetes, where the blood vessels can get coated with sugar and you don't get the brain as much blood. We talk about smoking. The nicotine can constrict blood vessels as well. And so those are the top 3 reasons for most of the time preventable strokes: blood pressure, diabetes, cholesterol, and lipids also coat the inside of blood vessels, keep the blood from getting to the brain. So, as far as things that we can do, as far as preventable risk factors, is managing that blood pressure, making sure we're not diabetic. And if we are, trying to keep those blood sugars to normal levels, trying to keep our cholesterol numbers and our lipid numbers down, and of course, avoiding smoking. And then the last thing is physical activity. We know that the more you exercise, the more active you are, you actually get more blood going to the brain, because you've got to be able to keep everything going. And so whether it comes to dementia or whether it comes to stroke, we really need someone to stay active, because that's one of the ways that we can try and help reduce the risk for stroke.
Right. Yeah. There isn't much of anything that a little more exercise and activity doesn't make better and less risk when it comes to medicine that way. I sometimes get questions from patients or concerns about statin medications that, it might affect my, there's been case reports or concerns about people getting confused or increased risk of diabetes, which I can speak to a little bit too as well, but with statin medications. Can you talk a little bit about the relative risks and benefits here of people for whom statin therapy is indicated?
Well, I think definitely if you are an middle-aged older adult and your bad cholesterol or your triglycerides or your total cholesterol numbers are abnormal, and especially if you have other risk factors, then it's something that I think is absolutely indicated before a stroke. But once you have a stroke, in my world, I don't even care what your numbers are. I do check it, but you absolutely need that statin. I counsel my patients that statin drugs are kind of like liquid plumber or Drano. And I don't advertise for any of these. I'm just saying it helps to clean out the inside of blood vessels. We're trying to break down plaque. We're trying to break down anything that's coating the inside, because the goal is we need to get the blood going to the brain. So every adult who comes in with a stroke into the hospital or otherwise gets put on a statin. And the risk is, worth it at that point. The risk for any other complication is much lower. For us as a community, as a society, it's much more disabling if you have a stroke and you're paralyzed and you can't talk and you can't move. You lose your independence. And I think all of us want to be as independent as possible into our senior years and be able to exercise and move and do things. We don't want to be fully dependent on anybody. So in general, if you're in the right population, you have issues with cholesterol or triglycerides, then it's important to get that treated. And the risk for other side effects and complications is far lower than the benefit that it gives.
Right. No, 100% agree. And the people who are indicated, that it's a critical thing. And I think it's a very important point that you bring out, that once you've demonstrated that you have vascular problems, you've had a stroke or you've had a heart attack, whatever cholesterol number you've had, that's relatively irrelevant. You've gotten into trouble at this point. You've demonstrated you're a problem child that way. And the statin medications not only lower your cholesterol and over time decrease plaque, but they decrease the inflammation. And when plaques fissure and crack, so if you have a little plaque on the inside of your vessel and that cracks, your body sees that kind of as an open wound and makes a scab over that, so to speak. And then you have that sudden blockage in that area. And those are things that statins can prevent as well. So we're not here to advertise for that, but I think that's a common thing that people will say, oh, my cholesterol has always been fine. Why are you putting me on a statin? And that's an important point. So among other medications, there's some other ones that are helpful. Interestingly, some of the newer diabetic medications are showing decrease in cardiovascular and cerebrovascular risk too. So some exciting times in what we can do to prevent this. And that's always the idea. If you get muscle aches and pains from a statin medication, we can take that away and they go away. If you have a stroke, boy, we can't fix that so well. So, okay. Well, we've already talked about common treatments. Is there anything else you wanted to talk about specifically with stroke, or should we start to pivot towards dementia?
Sure. I'm sure.
Okay.
Let's go to dementia.
So Dr. Joseph and I are teaming up for the CGH Health Foundation's appeal this year to help with dementia. It is a very difficult problem, one that a lot of us have personal familiarity with, including myself and my own mother. It's a difficult problem, not only for the patient, but for the caregivers as well. And we're trying to address and beef up some resources in the community. So, what are some of the latest research pointing towards causes? Everyone wants to know why. Why are we seeing more dementia? Why is it a bigger issue these days?
Well, the good news is we're living longer. So if you only live to age 40 or 50, then the risk for dementia is much lower than if you live into your 80s and 90s. And the brain over time, just like we were talking about for stroke, starts getting coated on the inside. So one of the opportunities is that you can have multiple small silent strokes or other issues, cerebrovascular disease, coating of those blood vessels that I keep talking about. And that's one variety of dementia. Dementia simply means memory issues. And I counsel my patients that there are multiple varieties of dementia. Alzheimer's is the most common, but there are other varieties, and vascular dementia. So trying to ensure that cholesterol, diabetes, blood pressure, all of that is good is a way to help prevent that type of stroke. So that is one cause of stroke. Sometimes medications can cause dementia. Medications can cause dementia too, or give adults difficulty with memory. So certain anticholinergic medications, things like amitriptyline in my world, or certain antihistamines can contribute to some memory issues. So we have to be careful with avoiding too many medications or polypharmacy. We have to avoid medications that could contribute to memory issues. If you have multiple head injuries, our athletes that have multiple concussions, or in general, if you fall a lot and get a lot of concussions and head injuries, that can contribute to dementia later in life. We know that if you're older than 65, you have a much higher risk for dementia compared to somebody who is in their 30s or 40s. And finally, I think toxins. So, we take for granted that it could be, genetics and other things, but also alcohol has been shown in studies to cause a high, regular high use of alcohol for a prolonged period of time can contribute to cognitive and memory issues later in life. So those are some of the known causes. There's always research going on trying to figure out, why do certain people have Alzheimer's versus others that don't? Does it run in families? We do have some genetics, but the vast majority of dementia is isolated. It's not something that is a genetic hereditary component.
Okay, thanks. Yeah, that's a good point with medications. It's often something that I think we don't do a good enough job of in medicine in general, is realizing as people get older, they don't metabolize medications as well. Doses that were good before become too much. Medications that were important before become less important, or the risk benefit goes upside down. Your medication you took to help your bladder issues, once it starts getting to the point where it's starting to affect your memory, you need to reconsider whether that's worthwhile. So that's a very, very important point. The toxins thing is really good as well. We don't always think of alcohol in terms of some of the acute effects, but there is that long-term kind of additive effect. And also, for the people, I have some patients that I just can't talk them out of drinking heavily, but there's a few things that we can do in terms of preventing, like a Wernicke-Korsakoff type of thing, where we can at least give them some thiamine and folate. So even if we can't make it go away entirely, it's worthwhile getting your friend or family or yourself in to do some harm reduction, if nothing else. All right. Is there any new developments in the way of testing? People talk about, well, should I get a 23andMe test, to see if I'm going to develop dementia? Is there value to that, or other things that we can do?
Well, I think the world is changing a lot as far as testing. In the last 5 years, we've been able to test for Alzheimer's markers in the CSF commercially, not just in clinical trials. So that's a huge improvement in our abilities to give a diagnosis. And I think that's important to families and to the patient to really understand this is what I'm dealing with and what is ahead for me. There's a new blood test called Preeti that's out on the market and that's been approved. However, no insurance will pay for it. So I think the cost retail is about $1,250. So we'll have to send it to a specific lab and they can actually tell us if somebody has Alzheimer's. So that's an option.
Interesting.
But then, we have PET scans that will evaluate for amyloid. And about 5-10 years ago, you could actually enroll in what's called the IDEA study and be able to get that done for free. But again, another test that no insurance company will cover across the board, but is also available in case somebody's interested in learning, particularly Alzheimer's variety. Sometimes we'll do a PET CT to check and see if there are certain areas of the brain that are simply not working as hard as other areas. And that can give us some insight if you have a dementia that's more frontal rather than the typical Alzheimer's variety. And of course, we do basic tests, things like blood work, looking for thyroid, looking for B12. We do MRI studies of the brain to really get a good idea. Have there been many strokes that someone didn't know about? Is there a tumor or is there some sort of lesion in the brain that's contributing to memory issues? If you have it in just the right area, you could be having other things that could be causing and mimicking memory issues from dementia that we may not have realized. So the important part is to get to a provider, to get looked at. If there's any question for some of these specialty things, of course, you'll have to probably come through neurology to do that. And I think we're getting better at being able to at least provide a diagnosis of Alzheimer's versus non-Alzheimer's. But and that helps with counseling on what's there to expect in the coming years for someone.
Right.
And more than that, I think even, I'm pretty encouraging, maybe is the right word for it. If I have someone who comes in their 40s and 50s and I'm really concerned, or even their early 60s, I'm really concerned that this is Alzheimer's, I will actually encourage you to get tested, at least with spinal fluid, and let's get a diagnosis, because I really want you enrolled in clinical trials, because that's really where we're trying to figure out, is there something that can arrest this process? Is there something that can reverse this process? And that's an incredible opportunity to really take control of this disease and see what's ahead.
Right. So, yeah, boy, I'm feeling a little old. When I was in training, there were a couple of sayings with regard to dementia. One, if you want a firm diagnosis, we got to do a brain biopsy, for Alzheimer's. Those days, thankfully, have passed. We have much better options. And the other saying was the best way to prevent Alzheimer's is to die young, as you're talking about. That's a sad. It was a very sad situation that is getting somewhat better. So you talked a little bit about helping people prognostically about what to expect. Can you talk a little bit about some of the testing that can be done to help identify what areas people have more preserved and how we can use that to improve the quality of life of people who do have a dementia diagnosis?
Yeah, we do send someone for neurocognitive testing, looking at really areas that they struggle with. Some people struggle more with visual, spatial, and directional areas of the brain. Some people struggle more with just the short term or naming. And so trying to identify exact area of weakness can help in improving quality of life. And so at the moment, we do screening tests in the office with what's called a Montreal Cognitive Assessment. And then if that sets a concern in my mind or in a provider's mind, then further testing can be done through a neuropsychologist. Unfortunately, we don't have one here in the community. So typically it's Rockford or the Quad Cities or Chicago. And then we started launching a program here that's computer based. We had a few issues with it logistically, and that's probably going to come back out. So you can come into our office and actually test and try and see if we can get similar results without having to go outside of the area and be able to, be more convenient as a resource. Right. So basically, memory testing is the answer to that question.
Right. So it's not just a more or less memory. It's what parts of the brain and how do you work around it? Do you use visual cues or verbal cues or that those sort of things? Mm-hmm. You mentioned a little bit about new treatments. There is a new dementia treatment that caused a whole big stir and people to resign from the FDA's panel, and it was pretty big deal. Can you talk a little bit about that and what your thoughts are?
So the drug is called Aduhelm, and it was $56,000 infusion every 4 weeks. And when we think about Alzheimer's dementia, we think there are plaques in the brain, protein deposits in the brain called amyloid. And so this drug is targeted to breaking up the amyloid in hopes of improving memory. Because if you have these amyloid protein deposits in the brain, the theory is that the brain cells can't communicate well with each other. And so if we break up, it's almost like breaking down the fence, then maybe the brain cells will communicate better. Our memories will improve. Well, there was a lot of discrepancy in the data, and neurologists and other specialists didn't agree that it was worth the benefit. So if you're going to spend $50,000 on an IV infusion for every adult who has dementia, there's got to be some substantial benefit to it. Mm-hmm. The other controversy came is that they gave it emergency authorization, which confused the whole insurance and coverage and all of that. So after giving it that authorization, now the FDA has pulled it back. So unless you are part of a clinical trial, you can't have the medication unless you've already been started on it. So here in our community, I do have one patient on it, and they go and get infused at the Quad Cities, and they were in it prior to some of the pullbacks from the FDA, but it was just the right patient for that trial. And as of within the week, I think a lot of the senior members of Biogen who launched Aduhelm have been released from the company, so there's a lot of controversy still going on. But there is another drug in the works. It's lecanemab. I can't spell it and pronounce it very well, but it's another antibody, monoclonal antibody type of drug, and it's actually going through the full authorization for FDA. So it's kind of the one that everybody, I think it's by Eisai Pharmaceuticals, but they're shifting their focus from Aduhelm. I think Aduhelm is slashing its push to be the drug of the day. I think part of the issue and the controversy is we haven't had a drug on the market for memory for years. I think 10 or 12 years between the last drug that was given the green light to this one. And so people are so hungry and so in need of something that there was concern that the adequate steps were not taken to truly ensure that it was worth giving the medicine. And it's not just cost, because if you break down the protein in the brain, you break down the fences, so to speak, there's a risk for bleeding in the brain. And this individual that I have on this medication, after the 5th or 6th infusion, we actually have to do another MRI of the brain to look for bleeding. So it's a risk. And so we have to be comfortable that it's worth the risk in order to provide the medication.
Right. Yeah, no, I can very much, from my own personal experience too, understand that strong, intense desire to do something. And when there's something that we can do, it's very tempting to kind of push that through. And, drug companies are certainly not above, leveraging that sort of emotion to their own ends to a degree. But I think it is encouraging that there is the kind of rigors of science are still important, and we're still looking at that and trying to make sure we first do no harm, because as you talked about, there is harm that could be done. So interesting. It definitely still has a place for further research. There may be niches, there may be places for that, but as far as being the thing. So before we let you go, let's talk just a little bit about what the foundation is doing in terms of local resources. There is some support groups, because as we know, it's not only the patient, it's the caregiver. Often the caregivers are kind of a second patient or a second victim. So we're working at some support groups in the community, and more information will be coming out on that. Do you want to speak to any other stuff as far as what the foundation is doing and why it's important?
I think they're the support groups, and then just the information from different agencies. Sometimes as a caregiver, your practical needs are not always met when you come see me, because I am wanting to make sure that you're on the right medicine or the right treatment, or I'm looking at all those things. But, as a caregiver, you want to know, if I need to go to the grocery store, how can I leave my loved one at home? Or what do I do practically when they ask me the same question for the 50th time that day? These practical things. So there's a lot of, as you said, support groups, but online information resources. They're trying to collect books and resources that the community can have access to. And I think they're trying to set up talks and things in different areas too. So I think coming together as a community, sharing resources, sharing experiences, I think is powerful in trying to help every one of us understand not only the medical part of it, but the real life part of it. And so the foundation has done, it's amazing the efforts that they are launching to try and help in that regard.
Yeah, there's a lot of a lot of us who are on the team for the foundation have a very personal stake in this and personal experiences. And so I think there's a lot of motivation to really improve care in the community for the patients and their caregivers, and a very worthwhile thing to be pursuing, and hopefully filling in some of the funding gaps as well. So again, thank you very much for your time and all that great information. Much appreciate your taking the time out today to share it with the community and all you do for the foundation and the hospital. So thanks again. Any closing thoughts or words, or we'll move on to COVID?
So nice to be here. Thank you very much for having me.
All right. Excellent. Take care. All right. So, boy, when Dr. Bird asked me to do this a few weeks ago, I thought it was just going to be great. We're back in. We hadn't had anybody in the hospital for a little while with COVID. Numbers were down. Summer's coming. I was hoping that I'd have an easy job today. Unfortunately, boy, we're starting to see an uptick. It is not like before. Let me be clear that the hospital is not being overwhelmed with COVID. The problem is, part of the problem at the moment is, since we've taken masks off and are all getting back together, all the other things are back to a level. And I guess it gives me an appreciation for how much we suppressed that when we had COVID. When COVID was really, really busy, if we didn't have COVID at that morning, the hospital would have been half empty. When we had 40 patients in with COVID, we didn't have a lot of other patients in. Right now, the hospital is very full, to the point we're putting people on wards they wouldn't normally be, and holding people in the ER because we don't have rooms for them at the moment. And not so much because of COVID, though I understand we have 5 patients with COVID in the hospital, nobody in the ICU right now. But because of all the other things, the pneumonias, the emphysema exacerbations, strokes, all that sort of stuff. We had a kind of a run of influenza as well, which we hadn't seen before. So the hospital is busy for a lot of reasons. So I hope we don't get too far down this road with COVID, because it's we're already stressed a little bit from all the typical normal stuff that's rebounding a little bit, it seems, from before, after, we were so careful for so long. And, we got to live our lives and do the things. And I'm very much all about that. It is probably a time to be a little more thoughtful and careful about big groups if you're a high risk person and that sort of stuff. Masking those situations. And I'll get to immunizations and boosters in a little bit. But first, Matt, if you could put up some of our local numbers here. So our 7-day case rate is 166.7 per 100,000. That leaves us still in the low range, which is good. It's just definitely an uptick. And hopefully we have enough pre-existing immunity from all the Omicron that swept through here over the winter and early spring immunizations. And it definitely feels different from my point of view, and that I'm seeing more people with nuisance infections, reinfections, breakthrough infections. I'm seeing less people kind of really crashing and burning with COVID, a lot of people who are kind of miserable. But I think that reflects the relative degree of immunity. I say relative because immunity is that. It's a scale, and not, and people think of immunity as a force field. It's more or less. And again, I'll get to a little bit about immunizations and previous infections in a bit. So percent of Whiteside County residents greater than 5 fully vaccinated. Now, what they're saying is fully vaccinated is still 2 injections, though that is certainly not optimal, but it meets the definition of fully vaccinated is 61.7%. That and 58.1 of all residents of all ages are fully vaccinated. So that leaves a fair amount of people without. Some of those people have moderate risk because they've gotten their immunity the hard way, but they have it some. If that's been a long time or it was a mild case, that may not be very robust, and I would think hard about boosting that with an immunization. Immunizations are not chemotherapy. They are not going to cause you any reasonable degree of medical certainty. They are not likely to cause you any sort of long-term issues at anywhere near the rate that the risk of COVID is. Okay, moving along to a few of the other statistics. 10% bed availability. That's getting fairly low. Again, not from COVID, but from all the other things. This is all of Region 1 has 14 ICU beds. I think most all of our ICU beds are full around this time. So we're getting by, but we're definitely feeling the squeeze here a little bit. New hospital admissions for COVID was 3. That was actually a slight decrease from the week before. These are small numbers, so it's hard to read too much into that. There were several weeks where we had nobody in the hospital for COVID. That was glorious. We are not there. And we've had one unfortunate fatality, 226 total. So, okay, well, Matt, you can go ahead and move on to the next frame there. Now, the scale of this is a little deceiving because Omicron was so huge. That big hump we saw in January to March makes everything else seem small. So the little uptick that we're seeing is not quite as little as it looks. If we put this on a scale from Alpha or even Delta, where we were looking at, numbers in the 50 to 100 range, and that was the top of the scale, that surge would look a little bit bigger. As you can see, total cases are up about 40% in the last 7 days. We're definitely seeing that. We definitely have early treatments available, and they are available locally. Paxlovid, despite I've seen on the news a lot of stuff about it's not available, you can't get it. I'm not finding that to be the case locally. We seem to have that pretty readily available for patients. Paxlovid does have a lot of drug interactions, so That is something that we have to be. It's not for everybody that way. I had a patient this morning that couldn't get it because of drug interactions, but they could get monoclonal antibodies. That's the number 2 tier. Second, because its numbers aren't quite as good as Paxlovid. And of course, it's a little more invasive treatment. You got to get an IV and all those things. But those things are available. It's critical, though. You have to present within the first 5 days of symptoms for Paxlovid to work. And so if you wait till it's bad, you've waited too long. So if you're a high-risk person and you have cold symptoms and it seems really mild, please get tested some way, some form. Shield testing through the high school, testing through the health department, Ready Care, even a home test. Keep in mind, home tests don't pick things up quite as early. They're pretty good at identifying whether you're contagious, or at least very contagious at the moment or not, but they're not quite as good as saying, are you in the very first day, real early on. So if you're going to do that, at least think about retesting if your symptoms persist. But so important to get that in early, a little bit like stroke. It's a real tragedy when high-risk people come in and all the methods for early treatment have those ships have sailed. So please get tested, get in early. We can get you in for telehealth appointments. You don't have to necessarily come in if you have a positive COVID test. I can see you in telehealth, and I can get you hooked up with Paxlovid the same day, or monoclonals in the very near future, same day or next day, typically. Still at this point, the patient that I had this morning that couldn't have Paxlovid is getting monoclonals tomorrow. So there are definitely things we can do. It's much less depressing that way than it was early on. But again, there are still some opportunity for tragedy here in people who decided not to get good protection and decide not to come in early. If you're one of the amazingly fortunate people that have not gotten vaccinated and not had a significant case of COVID, by significant, I mean you tested positive, you were really feeling sick for a while, so it was the case, and it was enough that it really made your immune system spend some time working on this. If you're in a situation where you haven't had one of those, you've been incredibly fortunate. The misconception is, I've gotten this far, I work with people, I've been I've been exposed to it, I must be immune. That's a real dangerous pitfall. Those are the people that when they do get sick, sometimes get really sick. And the last patients in my own practice that I lost were in that situation, and that's a real tragedy to see. So and I promised I would talk a little bit about immunizations and boosters. So let's get to that. So yeah, we have a question about, do you feel getting the second booster is needed right now? We were thinking of waiting until this fall for the second booster. Yes, and up to about 2 weeks ago or so, I was thinking that's a pretty reasonable strategy. Our cases were really low. Moderna is thinking about coming out with a more Omicron-specific variant. That might be, a nice improvement on the protection that it gives us. And I thought sitting tight and waiting was certainly pretty reasonable, especially if you're not a high risk person and it's your fourth shot. If you haven't gotten your first booster, definitely the case. Now that I'm seeing cases uptick, boy, I'm certainly thinking harder about that. In fact, I don't know, is my Band-Aid still up there? Yep, there it is. So if that answers your question, I got mine this morning. I am now over 50. I'm not particularly high risk, but being a healthcare provider, I got my booster very early on. So it's been a long time, and I am over 50. So I decided to go ahead and get it this morning. I decided it's time. We're seeing enough that I think it's worthwhile to get it now. And it looks like it'll be a little while before that Omicron-specific booster is available. because they're trying to figure out whether they're going to how fussy they're going to be about incorporating which variants. There's this new BA.2.12 subvariant of Omicron. It's still Omicron, but it's a little tweaked version of Omicron that seems slightly more infectious. So that may push things back a little bit. So in summary, if you're a higher risk person, you're one of the patients that we talked about before, and I said, you might think about, seeing how things play out for a little bit. You're over 50, or you have any sort of moderate or severe immune compromising illness, and you've waited, I would definitely get it now. I think it's time, because of the uptick we're seeing. It just doesn't look like we're gonna have. I was really hoping we'd get through the end of the school year before any sort of resurgence happened, and then kids are out of school. Summer is here. Things might be better, but it just didn't quite happen that way. So I'm having to change advice that way and say, yes, I would get a fourth shot if you're eligible at this point. And I don't think it was ever unreasonable to do that. But for people who, were hesitant and wanted to wait, I thought that was a little bit more reasonable to take that into stronger consideration. Right now, I would twist people's arms a little bit more to get that done. Again, if you're of most any age, 12 and up, at least anyway, where you're eligible for a third vaccine and you haven't gotten that, you've only gotten the first two, please do that. There is a large increase in protection, especially in terms of severe disease, but also, at least for a while, in terms of infection. Now, there is that in terms of trying to stop this right at your nose and not get any level of infection. That effect is shorter lived, and so I thought it was reasonable to try and time that a little bit better to when the risk would be greatest. But since the risk is here, time is probably now, and then we may have to do something again in the fall, maybe with that Omicron specific booster. So that's where we're at. Again, if please don't fall into the trap that I've been immune all this time, so to speak. I haven't gotten immunized. I must have superpowers. I can assure you that that's unlikely. You might have a light case, but you may very well not. And of the population of people who've gotten into real trouble, those are often the people. If I just look at the people in my practice who've had the bad outcomes, it's often been those people. One that really comes to mind is a healthcare provider who their whole facility got it, and they were the only ones who didn't. So they felt that, and I understand where that comes from, but it eventually broke bad on them as well, and not in an insignificant way. So that's the one lesson. And then, of course, from there, the benefits are more incremental. If you've gotten some protection, benefits from there incremental, but I think they're useful increments. And in the situation we're at right now, I would do that. Okay. Do we have any other questions from the community? All right. I don't see any coming up. I'd like to give a brief plug for the Sip and Trip podcast that'll happen on Friday. My daughter will be on that, talking about how she's involved in some charity work with something called the Borgen Project. So please tune in tomorrow at 6 to the Sip and Trip for Sarah Kuhns and myself. We'll talk a little bit more COVID as well, but we'll talk about saving the world. So thank you guys for your time. Hearing nothing else, we'll sign off, and you'll be back to Dr. Bird and regularly scheduled programming next week. Take care.